Hello, everybody. My name is Ira Byock. I am here at the Institute for Human Caring in Los Angeles, California. I want to welcome everybody who's viewing through the internet for the International Palliative Care Network. It's wonderful to be invited to present to you. Today, I want to give a concise version of a talk that I've worked on for years that looks at the subjective quality of life of people who are seriously ill and know that they are dying. The title today is Opportunity Within Crisis, the Human Potential for Well-Being Through the End of Life. My learning objectives are pretty straightforward. To apply a conceptual framework and language or terminology of human development to bring, for the purposes of bringing specificity to our psychosocial and spiritual assessments of patients in hospice and palliative care. To hopefully enhance our care planning, particularly counseling interventions for people who are seriously ill. And by having a conceptual framework and a terminology that is acceptable across our disciplines and hopefully across ethnicities, to be able to have a common language for cross-discipline collaboration in counseling and helping people through these difficult times of life. This starts by getting our language right. Confucius, supposedly some 3 millennia or so ago, said, "The beginning of wisdom is to call things by their proper names." In healthcare, however, we tend to call illness, and certainly terminal illness, through medical terminology. We have, in a sense, defined illness and dying as fundamentally medical problems to be solved, and we use a problem-based language to do so. I suggest that that's where we go astray in mainstream healthcare. The fundamental nature of illness and dying isn't medical, it's personal, intensely so for the ill person and everyone who loves that person. Indeed, whenever one individual gets a serious illness, the patient's family, all who loves him or her, shares in the illness experience. One person gets a bad diagnosis, cancer, heart failure, liver failure, whatever, and the entire family shares in the illness. Now, obviously, serious illness and dying are partly medical, but ultimately, from the perspective of the people who matter most, the people going through it, they're personal. In healthcare, certainly in the United States, we teach our medical students and nursing students and interns and residents and fellows through the language and the conceptual framework of medicine. And medicine is a problem-based model. It started in antiquity, of course, with the twin human health problems of illness and injury. And our goals in medicine are to cure, to prolong life, make it as good as possible, to restore health, or to restore function, independence. And then in palliative care, to relieve symptoms and suffering. And I draw this because that's the problem-based box within which we teach young medical and nursing students to think. It's been reinforced in since the 1970s by the problem-oriented medical record of Larry Weed, professor at University of Vermont, which really transformed medical charting. For the first time ever, you could actually understand what the last physician to see the patient was thinking, what the problem was and what their assessment was and what the plan of care was. That was a revolution. Now, however, we've over-adopted, I think, that problem-oriented medical record and the conceptual framework of the problem-oriented model, because it really constrains us to think that we're only legitimate in healthcare if we're dealing with somebody's medical problem. Our charting tools, certainly our billing tools in the United States, all depend on something being medically necessary, defined as responding to a medical problem on the chart. This tends to exclude formal assessments of the personal experience of patients. In palliative care, certainly we practice whole person care and family-centered care. And when, in addition to providing the best treatments for patients' primary diagnosis, their cancer, their heart failure, their comorbidities, treating their infections, treating their, when it comes to treating in a purely palliative sense or hospice sense, alleviation of symptoms and suffering must be our first priorities. And that, in fact, you can talk about that within the problem-based model. But they happen to persons. Dr. Eric Cassell, years ago, first in an article, then followed by a book called The Nature of Suffering and the Goals of Medicine, gave us a conceptual framework for personhood. He said that all patients are persons, and persons have multiple spheres of experience. Certainly we have our bodies, which are under assault for patients with serious incurable illness. We have our feelings, our thoughts. But he also said we have a past, which nobody can take from us. We have a family. Actually, most of us as adults have at least two families, a family we grew up in and a family we live with now. Sometimes we meet patients who have had several families during their adulthood. They've had a first marriage and family and then another. And that's part of who we are. Persons have a sense of the future, which for the people we care for is often directly under attack. We also have our own unique personhood, our own styles, our own ethnicities. We have an ethnic and perhaps a religious culture we were born into and grew up in and assimilated, but we also have our own very unique way of expressing that and experiencing our ethnicity and culture. We have a sense of meaning in our life. We all have an unconscious domain, which for most people is available to us mostly during sleep, through our dreams, but toward the end of life may become a more prominent part of people's waking consciousness. So Cassell uses this multidimensional model of personhood to define suffering as opposed to just physical pain. He says that suffering occurs when an impending destruction of the person is perceived, and it continues until the threat of disintegration has passed, or until the integrity of the person can be restored in some other manner. So for Cassell, the very nature of suffering has to do with this sense of impending disintegration, as if you were being pulled apart. This is the best graphic depiction of this level of suffering that I've ever seen. I hope you can see it. The colors are a little muted on this projection. This is one of Frida Kahlo's self-portraits. Frida Kahlo was a Mexican surrealist artist, the wife of Diego Rivera, the famous Mexican muralist. If you know anything, if you've seen the movie Frida or know anything about her history, she was injured in a bus accident, underwent many surgeries, and as you can see here, she had multiple sources of physical pain, nociception. But notice how she's depicted herself, as if without these external supports, this truss, the rents in her body are so severe that she would literally fall apart, disintegrate. That's suffering. It's a whole person experience. The other thing that I know sort of conceptually about suffering is well conveyed by the work of Viktor Frankl, who wrote Man's Search for Meaning. Frankl was a Viennese psychiatrist who was captured and interred in a concentration camp during World War II. He survived, and having been freed from the concentration camp, about a week after he was freed, he wrote Man's Search for Meaning, an account of his observations both in his psychotherapy practice and in the camps. And he asserts that for human beings, suffering is not strictly limited to nociception, to physical pain, physical deprivation, but is more closely understood as requiring a felt loss of meaning and purpose. So that when you're suffering for a higher purpose, it's suffering of a different sort. Think about soldiers in battle suffering to save the lives of their comrades or to defend their homeland. Women in childbirth, this is my own experience having delivered some 300 babies earlier in my career, Women in childbirth go through an enormous amount of physical pain. But rarely do they talk about suffering in that nature, in this nature of it attacking their personhood. Indeed, it enhances the source, their sense of meaning, and often solidifies their sense of personhood. But Frankl asserts, and he tells stories about people who, once they lost any sense of meaning and purpose, suffered grievously, whether they were physically ill or being deprived in the camps, or were well-to-do and seeking him for psychotherapy. Suffering is a whole person experience. If you think about clinical depression, which is in a sense a subset of suffering, within that syndrome of deep depression, often within suffering, there seems to be no hope for the future, a loss of any hope, any sense that it will ever get better. We know from clinical depression, those of us who are doctors and nurses, that that's part of the syndrome. It's not that the person is without hope, but the sense of being hopeless is actually diagnostic. So alleviation of symptoms and suffering are our first priorities in hospice and palliative care, but they're not our ultimate goals. Now this starts to get challenging to our usual conceptual frameworks, because within the model of medicine, it seems that if we could alleviate symptoms and suffering, that would be our highest achievement, our highest goal. But anthropologically, we know that when we have fully addressed, competently addressed people's physical distress, their nausea, their bowels, and the concerns that their families will be a burden, often there's a quality of life there, and people experience life as still worth living. Let me tell you a couple of quick stories. This is Mrs. Holeen. That's her real name. I met her when I was a hospice medical director in Missoula, Montana. It was well before HIPAA. So I speak her name with her permission and without violating any regulations. Mrs. Holeen had moved to Missoula, Montana to be cared for by a sister who lived there. I met her when she was dying. I saw her as the hospice medical director, made a home visit, certified that she was dying. Mrs. Holeen always reminds me of this quote from Myrna Lewis and Robert Butler, two of the founders of geriatrics in the United States. They observed all the truly significant emotional options remain available until the moment of death. Love, hate, reconciliation, self-assertion, and self-esteem. Here's Mrs. Holeen again. She insisted that we take this second picture. She said, if you're going to show them my picture, show them this one too. And she popped on her clown nose. Clearly, Mrs. Holeen's self-esteem was intact. Her sense of humor was intact. But I show this and I tell this little story to make the point that while Mrs. Holeen was dying, I mean, she was officially dying. I had just signed her up for the hospice Medicare benefit. She was certifiably dying. She was also fully alive. Mrs. Holeen was living during the period of time that we would refer to her as dying. And that's a key distinction. That while often in English we use the terms dying and death interchangeably, death is beyond life. It's a lifeless state. That's why I object to the term good death. I don't know what a good death is. I don't know if a rock is having a good day or a bad day. Never been there. But dying is a part of living. And I don't know about dying from having done it, thankfully. I've never been, had a life-threatening condition. But like many of you, I tend to hang out with people who are dying, spend time with people who are dying, and have long asked them to share their perspectives with me, so that I can be a better doctor and, frankly, a better teacher. One of my friends and also teachers was Bill Bartholomew. Bill was a pediatrician and an ethicist, a pediatric ethicist at the University of Kansas Medical Center. Bill was diagnosed with adenocarcinoma of the esophagus in June of 1994. At the time, it had advanced through the muscularis, and he was told that it was incurable and that he probably had a year or so to live. Thankfully, that proved wrong, and he lived over 5 years. And thankfully, Bill wrote while he was living with his illness. I want to read to you a few paragraphs I've pieced together from an article that he wrote and published about a year after he was diagnosed, published in the University of Kansas Medical Center Bulletin. It's called Living in the Light of Death. Quote, "It's been a little over a year now since I discovered that I have a fatal illness. In trying to explain to family and friends what having this period of time has meant to me, I have found it helpful to characterize it as a gift. It has allowed me time to prepare my family for a future in which I will not be physically present to them. It has given me the opportunity of tying up all the loose ends that our lives all have. I've been provided with the opportunity of reconnecting with those who have taught me, who have shared their lives with me, who have touched my life. I've been able to reconnect with those from whom I had become estranged over the years, to apologize for past wrongs, to seek forgiveness for past failings. But even more than all these, this gift has provided me the opportunity of living in the light of death, to live with life with death sitting on my shoulder. It has had a powerful effect on me, my perspective on the world, and my priorities. I like the person I'm becoming more than I ever have before. There's a kind of spontaneity and joyfulness in my life that I had rarely known before. I am finally free of the tyranny of all the things that need to get done. I realize more than I ever have before that I exist in a web of relationships that support and nourish me, that clinging to each other here against the dark beyond is what makes us human. I have come to know more about what it means to receive and give love unconditionally." And he closes, "To live in the bright light of death is to live a life in which colors and sounds and smells are all more intense, in which smiles and laughs are irresistibly infectious, in which touches and hugs are warm and tender, almost beyond belief. I wish that the final chapter in all of your stories can be one in which you are given the gift of some time to live with your fatal illness." Now that's a different mindset than most people have. Most people want to, die suddenly, struck by lightning on the 18th hole, just after they sunk the birdie, or, live to 105 and then be shot in the back by a jealous boyfriend, something of that nature. But there he is saying, no, it's a gift to have some time to live with your fatal illness. Indeed, anthropologically, this time of life offers opportunities. You don't have to have a religious, spiritual, framework to acknowledge that sometimes people recognize opportunities during these times that they haven't taken advantage of. Opportunities to communicate sad news of your diagnosis and illness, or sad feelings with others. Opportunities to complete your relationships, to make sure nothing's left undone or unsaid. Opportunities to complete your business affairs, getting that will revised or updated or filed for the first time so that your family doesn't have to go to the courts to transfer your possessions. Opportunities to turn over projects. Opportunities to give people your password so they can get in and close your Facebook account. Whatever it is. Opportunities to resolve previously strained relationships, perhaps between a father and son who haven't spoken in years, perhaps between a married couple who were married for 20 years before a bitter divorce. When one or the other is seriously ill, it may matter to them to get back in touch. Sometimes, the bonds that unite us begin to look bigger and more strong than the transgressions or the anger that has divided us. A chance to grieve together the impending loss of life and relationships, and a chance to review life, to tell one's stories, to explore what has given meaning and purpose to life, to explore those realms of the transcendent, that connection to something larger than the self, which is part and parcel of human life. Be careful about this phrase. I hear it all too often. people die as they have lived. Now, that's a half-truth. Some people do die as they have lived, and if that's what they want and they're able to pull it off, that's entirely their right. But some people change in remarkable ways during the months, weeks, and even days as they approach death. And if it's meaningful to them, they have a right to do that too. I call attention to this because so often we teach it to new doctors and nurses and new hospice and palliative care volunteers, and they come to think of it as being predictive. That if people die as they've lived, then why bother with all this counseling? Why bother with life completion and the like, right? I'm here to tell you that would sell us short as a discipline, as a caring model. It would make us constrained by that medical model, so that the best we could hope to deliver is a better medicalized end-of-life experience. There is opportunity during this time. Here's another patient, Charlie Counts, real name also before HIPAA, but I speak his name with his full permission. Charlie was a hospice patient that I came to know, again, back in Missoula, Montana in the early 1990s. By his own description, Charlie was not a very nice guy, Dr. Byock. He was a building contractor in Alaska and Montana, and had broken relationships. He had things that he was not happy about, not proud of in his past. When I met him, he told me that he had lots of work he wanted to do. He reached out to people during the year or more that we cared for him. He made amends, he apologized, he made new friends. Here he is, Charlie had poured his own headstone and carved it. He told me with a wink in his eye that it was important for him to carve his own headstone because, Dr. Byock, I want to make damn sure what's printed on it. He wasn't sure that he was going to be honored and celebrated. The Charlie I knew, by the way, was a nice guy. He had changed dramatically from the person he described himself as being even 5 years before. There was a tenderness, an openness, an honesty, a transparency, a vulnerability that was endearing. So I suggest that problem-based model that we've all been taught needs to stretch, and that just as we've done in early childhood, we should acknowledge that human development is a lifelong process. Maslow, Erickson, Piaget all said human development extends through the end of life. In our field, we're just proving by our stories of the people we're privileged to meet that it's in fact true, that human development can extend through the very end of life. So what does counseling and supportive, counseling for life completion and the like look like in a developmental framework? Well, I haven't invented any of this, and I've given a handout to you with developmental landmarks and task work, but let me go through them very quickly, and I will go quickly just for the sake of time. What I'm going to do is, remember that model, that multi-sphere model or circular model of Cassell's? Well, set it aside in your mind's eye, we'll come back to it, but think about every human being as a big concentric sphere of layers, like a big candy jawbreaker with different colored layers. And if that's a person, I want to work from the very outside gradually in, and by completing each layer, allow it to become more porous or maybe dissolve a bit. So the first outer layer is, the landmark is to achieve a sense of completion with worldly affairs. That's the legal affairs, the business affairs, the deed, the will, the title of the house, or title of the car, the deed of the house, and the like. And underneath is the task work, the transfer of fiscal and legal affairs. The way I counsel people on this is we just do a little environmental scan on their legal affairs and business affairs. If you were to die suddenly today, as any of us might, would there be important things left undone? Responsibilities or things that you want to complete or turn over, and business affairs not done. A little deeper. Sense of completion in your non-intimate relationships. If there was anything, you were to die suddenly today, as any of us might, are there people you want to have said goodbye to, have said anything to? your classmates, your colleagues at work, your people in church that you don't know intimately, but that you see, the guy who cuts your lawn, the barista at the place that you have coffee. If it's coming time that you may not be seeing them again, this might be a time to say, it's been good to know you. I've been pretty ill, and I don't know how much I'll be in to see you anymore, but thanks for all your service, and, if I don't see you again, goodbye. A little deeper still, a sense of meaning about one's individual life. And the task work here is things as simple as telling one story, doing a life review, maybe around a picture album with an MP4 player open, and you're just flipping through with a grandson or grandchild or daughter or son or neighbor, and with the recording running to just tell some of those stories. In telling stories, it turns out, this is highly therapeutic. Indeed, Myrna Lewis and Robert Butler called attention to it years ago. The therapeutic possibilities of life review are complex. There's an opportunity to re-examine the whole of one's life and to make sense of it, both on its own terms and in comparison with the lives of others. Identity may be re-examined and restructured. There's a chance to resolve old problems, to make amends and restore harmony with friends and family. Just telling stories without having to push in somebody's face that they're dying, and without putting them through traumas. Like, you don't have to go back through everybody's trauma. If you're going to choose any theme, ask people about the good times in their lives. A woman named Verena Kast, a Jungian psychiatrist, has written a book about biographies of joy. It's called Joy, Inspiration, and Hope. And she uses a therapeutic technique of asking people to reconstruct their earliest memories of being joyful, and starts from there. Not uncommonly in doing this work, people who have been quite somber and with a depressed mood will lighten up, will sometimes start to laugh in my presence. And I'll reflect back, isn't it interesting that with all that's gone on, you haven't lost your capacity for joy even today? Experience love of self. In a developmental frame, this is just a task that so often we've been neglecting. People so often in America are brought up by their loving parents more as human doings than human beings. We're taught that we're a good boy or a good girl if we achieve things. So at the end of life, as they approach the end of life, I often will gently, lovingly challenge people to say things like, out loud, like, I am not a bad person. Can you say that? And if they can't, I probe, gently about, well, what have you done now? Who have you killed this week? Everybody loves you and says you're a good person. What is it that you're not achieving? And I work with them in a very sort of lighthearted, loving way until they can say, I am a good person. I am a good person. If I had more time, we could go through some of the little counseling exercises that get you to this, get people to be able to say these things. Acceptance of worthiness. Experience love of others. Because other people can love you, and if you don't have a sense of being a good person, being worthy of love, the person can't feel the love that's actually coming toward them. Kubler-Ross, I've heard her say many times, every human being should experience at least 5 minutes of unconditional love. Those of you who have heard her speak, you remember that. Indeed, she's right, of course. And working with people to be able to feel the love of others is a developmental counseling tool and counseling work that is often life-changing for that person. A sense of completion in relationships, deeper relationships. This is the same task that we went through with the non-intimate relationships, your coworkers and vendors and the like, but it's more important and more impactful, obviously, when you do it with the people you love or once loved. Same process are there any things left unsaid between the people you love or once loved? Anything you want to say? Many of you know that for years I've been talking about saying the 4 things that matter most. They're not things at all, they're just 11 words, 4 sentences. Please forgive me. I forgive you. Thank you and I love you. Please forgive me and I forgive you, because there hasn't been a perfect relationship in the history of our species. Even the most close and loving relationships are often marked by instances of hurt feelings, sometimes real transgressions. Please forgive me, I forgive you, thank you and I love you is often like stating the obvious, but boy is it ever of value. This little tool, it may seem glib, but in counseling people with it, and I don't tell them that they have to do it, I wonder aloud if it wouldn't have value for them to do it. This has changed lives. Sometimes the story of a fractured relationship that ends well changes everything that has preceded. It becomes, prelude to a happier or a healthier ending. All of the years of anger. The history of a family can change in those last weeks of life dramatically. This guy I've written about a lot. I call him Steve. It's not his real name, but that's really the character. His real name was Arnie. And it changed his family's life just by coming clean and bearing his heart. Deeper still into the deep psychology or existential psychology, accepting the finality of life, one's existence as an individual, with the task work of acknowledging the depth of the loss of one's life and all relationships, expression of the depth of tragedy, but also a decathexis or an emotional withdrawal from the worldly affairs and a cathexis or emotional connection to something larger than oneself, whether that's nature or one's family, who will hopefully remember you for generations to come and you'll be part of for generations to come, or of course God or deity that you're going to be with. Whether it's from a spiritual or religious perspective or simply back into nature, that is a developmental opportunity for us. Even acceptance of dependency. Now, dependency for all of us will be a stressor. It will be for me. But it is part and parcel of being human. As we are born into several years of physical dependency, so too in the human community we will die after a period of physical dependency. That doesn't make us undignified. It actually makes us human. This is a species-specific trait, that we care for one another at both ends of life. Stephen Levine has talked about a sense of a new self beyond personal loss. So you're no longer a doctor and coach of your kid's football team, no longer a speaker, no longer a committee chair of this, that, or the other thing. Can't cut your own lawn again anymore, can't help around the house, and yet, today was a good day. Who are you now that you've lost all of that? And how is it possible that there can still be connection, meaning, something of value? We've seen this in so many patients. We often don't acknowledge it in our words because our medical terms don't allow for it. Achieving a sense of meaning about life in general. Now we are down into that transcendent or existential or spiritual realms. It involves things like the task work of achieving a sense of awe. Recognition that there is something larger than oneself, whether that's nature or God or however what terms one uses. There's a commonality for those constructs that are larger than oneself, and achieving some sense of comfort with a lack of control. That's why we teach relaxation techniques and breathing techniques and mindfulness techniques to patients, so that we can all become somewhat more comfortable with some sense of center despite not having control. And finally, the last developmental task and landmark are the same thing. This volitional letting go. Now, I actually think that more people achieve this sense of growth than we often acknowledge. First, because we don't have the framework and language to label it when we see it, but also because at some point in time, all of us become irrelevant to the person on this journey, or less relevant. That this is some place where we go inwardly, and this is task work that is so personal that it's hard to express. Remember that circular matrix that I showed you of Cassell's? What we can think of is that our work in counseling is to help people to complete spheres of their personhood that are no longer relevant to their changed life situation. As if this is another legitimate developmental phase of life. And to release them, to let them dissolve, while maintaining some integrated core of personhood. So our job or our professional roles may become less relevant. The fact that we drive a hot red sports car may become less relevant when we can no longer drive it for months. Those fancy pumps that we haven't worn in our closet, for women may become less relevant. Our politics may even become less relevant. Some friends we say goodbye to and then release as that relationship is now complete, right? And yet, we may retain a source of meaning, a sense of meaning of life, that there's an intrinsic sense of meaning in life. Our intimate relationships may still be strong. Our past may remain durable. The unconscious domain may become more important part, where people have this sense of nearing death awareness, this dreamlike sense of having people that present to them that have preceded them in death. The point is that in helping people to complete and release spheres of their lives, they may retain a sense of personal integration, allowing these parts to release so they become less dense, perhaps less corporeal and more ethereal as they dissolve out of life, but never have to go through that depth of suffering of disintegration. So that's what I wanted to stress today. That in thinking about our therapeutic approaches to people, yes, we have to treat the medical problems, yes, we have to treat their pain and their bowels and nausea and itching and all the others, but we can also help them achieve a sense of completion of their life and relationships. That it's possible within the human condition to be seriously ill, know you're dying, even have substantial physical discomfort, and still have a sense of well-being, personal sense of well-being. To me, that is the highest therapeutic goal for our patients, certainly in hospice and palliative care, not simply to have their symptoms controlled, but to be able to retain or achieve a sense of personal well-being. For all of us, that we can affirm their inherent dignity, that people working with their families, we can honor and celebrate the people who are our patients through the very end of life. This time of living that we call dying can be rich and meaningful. All of us, in acknowledging that people are whole persons, can contribute to a healthy ending after a long, hopefully, meaningful life. Thank you all for the work that you do. It's a pleasure to present to you, and I'm in fellowship with you. Namaste.